So in the pre-surgery phase, the biggest thing, like I mentioned, is patient education and pre-surgery counseling. They get that handout that they take with them and can bring with them in the hospital. I know not all patients bring it, but we do encourage it so that they have that to refer to as they're recovering. They meet, of course, with one of the surgeons and then one of our nurses. There's a carbohydrate drink that they drink the day before surgery and then the morning of surgery as part of their bowel prep. We always warn the patients it doesn't taste very good, but it is very important to the recovery. It helps improve the glucose levels and the protein load just prior to surgery, which reduces wound infections and reduces postoperative ileus. Part of that also is part of our bowel preparation. We used to do a full mechanical bowel prep on a lot of these colorectal patients. We found that it just leaves them dehydrated as they're coming into the operating room. And so we now selectively give mechanical bowel preps, mostly for our lower rectal resections, but for like a right colon, they don't get a mechanical bowel prep at all. They get what's called a Nichols prep for the most part, which is an antibiotic prep, and some probiotics and these drinks the day before. So that also improves patient satisfaction. When I can tell them, hey, I don't have to give you one of those bowel preps like you had for your colonoscopy, they just light up. I mean, everybody hates the bowel prep. So that really helps. We use epidurals for pain control. A lot of these are placed in the preoperative area. We primarily use those in the patients that we're going to be doing open surgery on, but then we use regional blocks, which I'll get to in just a second, on those that we're going to be doing laparoscopic surgery on. So during surgery, and this is where we had the anesthesia teams really their buy-in on this, because it's a different way of treating the patient while they're under general anesthesia. The primary thing is goal-directed fluid management. They actually reduce the amount of IV fluids that they give. So we know with surgical patients, they go through the post-surgical inflammatory response that creates the weeping of the proteins out to the tissues and that third spacing that we all know about. Well, that also third spaces into the bowel, and that bowel edema leads to post-op ileus. And so that's why you've seen us, they give less IV fluids during the case, and we're giving less IV fluids post-operatively, trying to saline lock them as soon as we can if they're tolerating PO, so we can reduce that bowel edema, which then reduces post-op ileus formation. Like I mentioned, judicious use of opioid pain medications. I'll get into this a little bit more, but in the pre-op area, the anesthesia team is actually giving them some oral pain medication regimens before we're actually turning those pain receptors on. They're doing TAP blocks, which is a regional block along the abdominal wall, and again with the other patients, as we expand this to thoracic surgery and gyn-onc, we'll be doing regional blocks for those patients as well. Using a laparoscopic approach when possible, we know that that reduces pain, reduces length of stay, reduces wound infections and post-op ileus. And then careful consideration of blood transfusions. Again, blood transfusions can enhance that inflammatory response after surgery and then can worsen the post-op ileus state. It also worsens oncologic outcomes in those patients who are having a surgery for a cancer-related reason.